Well, welcome to Clinical Minutes with CSI Pharmacy. I'm Sean Clem, and this is Shelley Stringfellow, and we are privileged today to be talking to Dr. Jonathan Bernstein from Advanced Allergy Services in Cincinnati, Ohio. So, Doctor, welcome to CSI Pharmacy.
Thank you for having me.
And so our topic for today is going to be PANS and PANDAS. So, Shelley, would you like to get us started off with the first question?
Sure. We would like to ask you, what is PANDAS or PANS?
Well, PANDAS and PANS are syndromes that have been coined to describe children. It stands mnemonic, it's pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. However, subsequently, PANS is a more broader description of other infections that can trigger this disorder. And typically, we still don't know what the cause of this is. It's thought to be an autoimmune condition where these children are susceptible through something called molecular mimicry, where they develop autoantibodies in response to these infections. And because they have defects in their blood-brain barrier, these antibodies can cross the blood-brain barrier. Normally they wouldn't, and they can bind to receptors in the basal ganglia that can lead to these acute mental and cognitive disorders. These manifest as extreme obsessive compulsive disorders, intrusive thoughts, tics, cognitive decline. So of course it's a heterogeneous condition and it affects people differently, but it's quite debilitating. It's sort of like walking off a cliff. They're fine one day and the next day they're not able to, just to really focus and do anything. So you can imagine the burden it has on the patient, but also on the family members and the loved ones.
Yeah, okay. So what kind of criteria are you using to diagnose PANDAS and PANS?
When we see these patients, we like to evaluate them, obviously through history as to what type of clinical criteria they have. And certainly some of the, there's many different clinical characteristics, but individuals tend to have, worsening obsessive compulsive disease. They have cognitive decline. Their handwriting skills go from very good handwriting to chicken scratch. They can't write. They aren't. They might have increased bedwetting. They might have a lot of other clinical features. A lot of tics. A lot of, as I said, intrusive thoughts, and unable to. They go from A students to D students, and they start able to function in school. So there's a lot of characteristics. We tend to look then clinically to see if they have immunodeficiency, or if they have some type of autoimmune disease or some kind of active infection, some acute or chronic infection associated with this decline.
What type of labs or any kind of imaging or testing is essential in that initial workup?
We do an immune workup, so we get immunoglobulin levels, subclasses, and total IgG, A&M levels. We do looking at vaccine responses, although not everybody has been vaccinated these days, but we do look at vaccine responses to see if their T cells are working properly. Oftentimes I'll get B cells, T cells, and NK cell subsets, and it depends on their, what their presentation is and how extensive of a immune workup. A lot of times we might start off with just that, get a CBC with DIP and as well, and we'll do a CMP and get a CRP and a SED rate and look at complement levels, as well as do some type of workup for some common infections like mycoplasma, get an ASO and an anti-DNA titer indicating strep. Some people are worried about Lyme disease and other tick-borne illnesses, and sometimes we'll check antibodies towards those diseases, looking at IgG and IgM. It's important to realize, though, that IgM, even if they don't have class switching, and they still have persistent IgM responses, that because those can linger for months, you may not switch for a long time. So we do look at IgM as acute infection, but it can also be misleading in some of these chronic infections. We look at CMV, we look at EBV as well, Epstein-Barr and cytomegalovirus, and then we do have some cursory autoimmune workup, typically an ANA, rheumatoid factor, maybe followed by a CCP, depending on if it's positive, and an ENA profile just to screen for autoimmune disease. So those are probably the initial workup that we look at in patients where we don't see any markers of that would support the diagnosis, and they don't always have positive tests. Sometimes they'll have high ASO titers, anti-DNase titers. I will also recommend something called a Cunningham panel, which is an out-of-pocket cost, but oftentimes is useful for telling us if they do have these autoantibodies that I mentioned earlier that are targeting the basal ganglia. So that's especially if we're going to, if we have, if the other testing is unremarkable and we want to use advanced therapeutics to manage these cases. Sometimes that's helpful because it could be a target for treatment response, looking at these antibody levels. So it does, there is some nuances, and it's not one size fits all, it's a heterogeneous population. Many times these patients have good response to antibiotics for a period of time, so that's a diagnostic clue. But if they aren't responsive or they are better on antibiotics and then you stop them and they come back, then we want to look at other things that are more definitive, and that might be immunoglobulin replacement therapy that knock out the autoantibodies, or to use plasmapheresis. There's other things that are emerging in the literature day to day, and that are still not overly proven, but we listen and we try to understand the evolution of the science to make sure we're not missing things to help these children and young adults.
Do you find genetic testing something that you look into, and if so, why, and if not, why not?
Not routinely at the present time, because there haven't been any real good consensus genetic markers to define this condition. There are other forms of autoimmune encephalitis that have associated autoantibodies like NMDA disease, but there's a whole host of these things. They tend to be better defined and associated with genotypic markers, but that's not what we're talking about here. At this point, more work is needed to phenotype and endotype these patients, and to really look at identified markers, clinical markers that are diagnostic of this condition. In order to do that, you have to have a very good phenotype. You have to characterize patients very well. Otherwise, if you just say everybody who has OCD has PANS and PANDAS, then garbage in equals garbage out. You won't be able to do adequate research to understand what's going on. So that's the charge of the clinician, is to really characterize these patients as best as possible, so we can have a better defined population that would allow us to understand more about the pathogenesis and mechanisms related to this condition.
So you mentioned using immunoglobulin therapy. So what would that look like in the, is it going to be monthly? Do you like to use subcutaneous or IV? And then is there a timeline for that therapy?
So originally, some of the original reports were using high dose treatment over 2 days, with like 1 gram to 1.5 grams. I've gotten away from that. I don't see that as being necessary. This was something reported out early on by Sue Sweeto. We do have to worry about, effects on kidney function and things of that nature. I have seen some bumps in creatinine, when you're giving too high of a dose and things of that nature. So hydration is really important. Typically, we would treat, I start off probably around 400 to 500 milligrams per kilogram, depending on the individual and their their profile, and then, you know, of course, we monitor their immunoglobulin levels, and I do this on a monthly basis. And I find that doing this on an ongoing basis is very effective, and not having to do these acute one-time treatments where you give it to them and you're done. It doesn't work that way. We've also used it, and we've transitioned these patients from IV to sub-Q, and they've maintained good control on sub-Q. So I think it's, it's more introducing the immunoglobulin into the circulation, into the system, so that it can absorb out autoantibodies and provide that anti-inflammatory response.
So when do you recommend IG?
Getting a blood test or back?
Oh, no, I'm sorry, just when do you recommend IG therapy? After trying other things, or do you, how do you?
Yeah, normally we'll try, depending on their profile, we'll try antibiotic therapy to see what kind of response they have, whether it's something that's targeting, whatever we see. The lab testing does give us some clinical clues as to which direction to take. A lot of people already tried antibiotics by the time we saw them, but we might try an extended course or use something that's more targeted towards what their suspected infection is. We'll do this for, it can't be for an extended period of time. It may be a month or even 3 months sometimes. I know that's controversial, and that's why a lot of doctors aren't really liking that. But, antibiotics have anti-inflammatory properties as well, and when used properly, I think they can be safe to use and so forth. So, and sometimes we see dramatic effects with this. So, sometimes we use steroids, corticosteroids, but that can make their condition worse. A lot of people can get very anxious and hyperactive, and it can make their overall condition worse. But it does help some patients, and sometimes we use NSAIDs and non-steroidal anti-inflammatories. That sometimes helps. So those are some of the treatments that we might use initially. There's been some talk about using statins in these patients to help repair the blood-brain barrier that might help indirectly. The data for supporting that is very weak, but I do use that periodically, and I've noted anecdotally that some patients felt it has helped. So, and they've stabilized, but that again, data is not overly strong. We have looked at other things like folate autoantibodies targeting, which might actually target folate receptors, and sometimes may, as a result in bad folate binding and folate deficiencies. So in the central nervous system, so sometimes we have to use other therapies like leucovorin that would bypass the folic acid receptor and see if that helps. But so there's a lot of iterations. It's still really a emerging condition. We don't have a lot of understanding of the pathogenesis yet, but there are some studies definitely showing benefit, and that there seems to be an autoimmune response here. So I think we're learning still, but we do have, relatively strong algorithmic approaches we take in the evaluation and management of these individuals.
So then, let's talk about a patient who maybe has had an incomplete response or has relapsed after IG. What do you do to manage those patients?
Well, if they're still on immunoglobulin, or they came off of immunoglobulin.
If they've come off of it specifically.
Yeah. Well, many times they're on it for a long period of time. They don't come off, because if they're putting them on it, it's usually for a reason, and it's not a short treatment. If they're doing really well and doing very well and clinically look good, we can spread the frequency out and maybe even reduce the dose. But I typically don't stop it so quickly. If we do see that, and maybe they are off of it because of insurance issues and that accessibility, then we try to get them back on it. We have used plasmapheresis with success as well, but and the studies show that it does have some benefit as well, but it may not have a sustained effect, and so these individuals often have to redo it after 6 months or a year, and they can see that it does help, but it's not sustainable. So that's why I think that the immunoglobulin probably is long term a better avenue depending on the case and their response. But that's really what we would do, is probably try to get it back on, get started. But that requires a lot of prior authorizations, a lot of discussions with payers, and so that can be quite frustrating. I know that there are some insurance companies now that are accepting the diagnosis of PANS and PANDAS, and that's largely due to the efforts of the PANS consortium and their lobbying for this and so forth. So that's does show that if you yell loud enough, then people sometimes listen.
Definitely. What is your view on prophylactic antibiotics for recurrent strep? I didn't want to leave this one out because several people asked this question.
Well, again, we have used antibiotics targeting strep or other infections for a prolonged period of time. So, we might use it for a much longer duration, obviously 2-3 months. Sometimes people are on it for 6 months. So it just really depends on the clinical profile and how they respond. Of course, when you use chronic antibiotics, it can change the microbiome and cause other unintended effects. There's risks for resistance, there's risks for infections, super infections, because of the resistance, and there's risk for drug reaction. So that's, we don't take it lightly when we start these medications, but we do see some long-term value here.
Okay, so are there going to be any clinical trials upcoming or planned? And then kind of what would those look like?
There was a trial where we recently reviewed the data for immunoglobulin replacement therapy, and it was from a group out in San Diego, and it was a small study. It was discontinued, so it was underpowered because they didn't think they were going to meet their primary endpoint. And they were only looking at OCD, and they weren't looking at other markers. And there's something called a PANS 31, which is a more comprehensive assessment scale that is currently undergoing about validation, and I think that might be a better way of assessing the overall effects of therapy on these patients. It's something we use routinely, but I think in the concern about doing studies, number one, they're expensive. Unless you have the right phenotype and the right endpoints, you may not hit your mark, and they do require a multi-center approach. And with rigorous protocol design. So, but I think there is a strong interest to move forward with this, to get this, to do such a study, to see to see the desired effect that we are already seeing anecdotally in the clinical setting. So it's important to do this so that we have options, so we have approved options for these patients, when they do present in our office.
So I do onboard a lot of the PANDAS patients that we see here at CSI, and I talk to a lot of parents and hear a lot of really sad stories, and they are going through a lot, like you said earlier. What do you wish that parents understood before starting IG therapy? Well,
I think they need to understand the disease, and that there's a lot of people come to me thinking they have it, but it doesn't really stack up to be PANS or PANDAS. And so it's like anything else. We're in the age of information, EMR, and media, and you can get information about anything. And if you put in your symptoms, you'll come back with a diagnosis. And many times you could put in those symptoms we went over earlier, and you'll get PANS and PANDAS. And that doesn't mean you have that necessarily. There's a lot of mimickers of these conditions, and all across the board, not just PANS and PANDAS. We have mimickers for every disease we take care of. So it's important that you meet with a physician who has knowledge and expertise, and go over the history and do the proper diagnostic workup and become knowledgeable. We encourage patients to be knowledgeable and to ask questions. It should not intimidate physicians. It should actually be welcoming, because an educated patient is a good patient, and they may not always have the right hypotheses, and that's the value of a physician, is to help direct them in the right direction, but to listen and to understand, try to empathize as much as you can. Obviously, you can't completely empathize unless you have a child, but sympathize for sure, and try to help them in the best way that's possible, which may or may not be immunoglobulin replacement therapy. It really depends on what they're presenting with and their, what their clinical profile is.
Now, so we talked about the patients having certain tics and behavioral issues and things like that. Do you feel like site of care has an impact on this therapy, and would it be beneficial to do this in the home versus maybe a clinical setting, keeping the patient comfortable?
Oh, I'm an advocate of home infusions for a lot of things, because it reduces cost, it improves, it does make it more comfortable for the patient. But I think that I would say that all of our patients are receiving, most of our patients, I would say 99% are probably getting the immunoglobulin in the home setting, whether it's IV or sub-Q.
What do you see as the future outlook for PANS, PANDAS? What's on the horizon?
I think as people become more aware of this condition and start taking away the stigmata that these are, crazy people looking for answers, and understanding that there is a strong underlying disease pathogenesis, and that it'll open doors for funding to do more research and substantive research by talented investigators, not just clinical trials, but translational research to understand what are good biomarkers, what are good diagnostic tools for understanding if there's subtypes of PANS and PANDAS, is there genetic linkages, what is the response, what is the treatment response to immunoglobulin replacement or other disease-modifying therapy. So there's a lot of things that need to be done. Starts at the bedside, clinically phenotyping patients, characterizing them well, and that's what we'll be able to then lead to understanding, for instance, differential expression gene signatures that would then lead us to good biomarkers for diagnosis. So there's a lot of things that need to be done still, a lot of gaps in knowledge. It's like any other complex unexplained condition. It requires a lot of work to really make them definable. And we have many examples of that in the history of healthcare and medicine, where people were thought to have mental disorders and making things up, when in fact they turn out to be real entities just manifested as these clinical symptoms. Asthma, for example, used to be a psychiatric illness, and Teddy Roosevelt had asthma. He was a Rough Rider, and he became a boxer because he thought he was weak-minded because he had asthma. It turns out asthma is an inflammatory lung disease that, if you don't take care of it, it'll kill you. Hereditary angioedema, they used to call these patients hereditary angioneurotic edema because they were always seeking drugs until they identified that there was a specific C1 esterase inhibitor deficiency, and if you replace them, these people get better. So there's a lot of examples. Porphyria is another example. There's a lot of examples where people present with very difficult to understand and believe histories, but when you start listening to them and understanding what they're describing, it's amazing what kind of information you can glean, and how you can make a difference in these people's lives.
So, Doc, we have a few more minutes left. Shelley, I think you had some additional questions. Did you want to ask anything?
I've had a lot of parents asking about that first dose of IG that they get, and it being given in 2 days. A lot of them feel like that's too much in 2 days. Do you have any thoughts on spacing that out, or doing 4 to 5 days? Are you against that, or what's the reason for the 2 days?
Yeah, that was just the way the protocols were done, and I think it was just meant to be a single treatment, and they monitored them for a year, and the Susuito study. I don't really approach it that way. Initially, I did give a high dose, and I agree it is too high, and they have side effects. I use just basically, as I said, 400 to 500 initially, and titrate up based on their clinical response, and I do it monthly. I don't just do it on one time out. I think that I've had good experience with that. Do I have clinical trials to confirm that? No, but We will at one day, at some point in time, but clinically, it does seem to help these individuals and it works well. It's better tolerated.
And we have a question for our pharmacist, John Payne.
Hi, Dr. Bernstein. Thanks for joining us today. I was just wondering about other triggers that cause the outburst of the patient, like food dyes. Do you see that, or like paradoxical reactions from like Benadryl causing the patient to be more hyper, or is that something that you see, or
We have patients who have paradoxical responses to antihistamines like Benadryl and other therapies. That happens with or without PANDAS. They can have strong reactions to steroids and so forth. There's a lot of other interesting neurogenic disorders and paradoxical responses that we see that we're starting to understand why they're occurring.